Good afternoon, everyone. On behalf of the L. Douglas Wilder School of Government and Public Affairs at VCU, we welcome you to the June presentation of the Wilder School Lunch and Learn series. Today, we have an amazing presentation entitled The Dobbs Decision, looking at the health policy consequences 2 years later with Dr. Wendy Klein and Dr. Sarah Jane Brubaker. If this is your first time joining us, welcome. The Wilder School offers a unique opportunity for learning and growth with our free monthly virtual events. Each session features change agents, thought leaders, and policymakers who provide insights and commentary on relevant topics of the day. My name is Stephen Dozier, and I'm the Senior Director of Development. Before we get started, I have a few quick announcements. The Wilder School remains at the forefront of our field as U.S. News, World, and Report ranks our public affairs graduate program 39th in the nation, putting us in the top 15% of our peer schools nationwide. Now is the time to apply to the Wilder School because next Monday, July 1, is the deadline for our fall applications for the programs that you see on the slide here. Please share the QR code or link seen here with friends, family, and colleagues who may be interested in attending the Wilder School in the fall. Lastly, summer 2024 Wilder School undergraduate and graduate courses are available now. Feel free to follow the QR code shown on your screen for more information. Also, check the chat for links to all our updates. Now I have the great pleasure of introducing our moderator for today's discussion, Dr. Sarah Jane Brubaker, a sociologist, professor, and assistant chair of the Criminal Justice Program and director of the Certificate in Gender Violence Intervention in the Wilder School. Her areas of expertise include adolescent pregnancy and sexual health, gender-based violence, and juvenile justice system reform. Dr. Brubaker is incoming president and chair of the Anti-Harassment Committee of the Society for the Study of Social Programs. Dr. Brubaker?
Thank you, Stephen. I'm really honored to be here today, and I'm particularly excited and honored to welcome our guest speaker, Dr. Wendy Klein. Dr. Klein received her medical degree from Case Western Reserve University and completed her training at VCU, where she then served on the faculty of the VCU School of Medicine for 25 years. During that time, she was a leader in advancing the health of women and co-founded the VCU Women's Health Center, the VCU Institute for Women's Health, the Women in Science, Dentistry, and Medicine organization, as well as the Health of Women, a scientific update for healthcare professionals, which continues to be held annually since 2000. She was a co-editor of the Journal of Women's Health from 2005 to 2011. Dr. Klein has served on numerous national initiatives and committees for the American College of Physicians, the Sex and Gender Women's Health Collaborative, the Menopause Society, and Planned Parenthood, where she played a key role in developing their primary care programs. She is a co-founder of Leaders, a national group of senior women physicians dedicated to promoting the health of women. Dr. Klein has been recognized among the top docs in Richmond and in the best doctors in America, and was awarded mastership by the American College of Physicians. She's medical director emeritus of Health Brigade, the oldest free clinic in Virginia, and was a gubernatorial appointee to the Virginia Board of Health from 2015 to 2023. She remains actively involved in promoting public health and in accelerating women's health research. She is a passionate advocate for access to health care, for reproductive autonomy, and for gender equity in every arena. Please join me in welcoming Dr. Klein.
Thank you so much, Dr. Brubaker, for that kind introduction. Hello, everyone. I was asked to speak today about the Dobbs decision, looking at the health policy consequences 2 years later. Next. And I'm going to begin with a quotation from someone at the, I admire very greatly, Dr. Lisa Harris at the University of Michigan, because this encapsulates the essence of where we are. The intense politicization of abortion in United States public discourse obscures its status as a health and healthcare issue. Next. So before I begin, I would like to share some facts with you, because we need some context. And abortion is a fact of life in the world and in the United States. 1 in 4 women will have an abortion in her lifetime. Be aware that unintended pregnancy is more common than you think. About 48% of pregnancies are unintended. 50% of women seeking abortion report using some form of contraception that failed. Also, please note that 93% of abortions occur at 13 weeks or less, and 4 out of 5 at 9 weeks or less. It's also worth remembering that almost 50% of women seeking abortion live below the federal poverty level. Next. So let's talk about the Dobbs decision. It's a 2-year anniversary now. It was handed down June 24th, 2022. And in that decision, the Supreme Court ruled that abortion is not a protected right under the Constitution, overruling 50 years of reproductive autonomy. And the legality of abortion then fell to individual states, creating a highly inconsistent and confusing patchwork of regulations. Next. Dobbs erased the baseline of legal protections at the federal level, such that reproductive autonomy became wholly constrained by geography and politics, and went from being a constitutionally protected right to a crime in more than 1/3 of states. Next. This is a can of worms. That is where we are. Next. This is a map that shows the spectrum of restrictions in abortion across the country right now. This is from May of 2024. The red states are the most restrictive, and the green states are the most protective. And you can see there is a patchwork of everything in between. Next. So post-Dobbs restrictions have had a profound impact, and today I'm going to try to address the spectrum of consequences that include the following: worsened health outcomes with increased maternal mortality and morbidity, healthcare workforce issues, barriers to medical training, threats to emergency medical care, threats to in vitro fertilization, and amplification of health inequities. Next. The situation that we're now in is exemplified by a case that came before the Supreme Court of Texas, Orozki versus the state of Texas, in which 20 women who were denied abortions sued the state of Texas, arguing that the state's abortion laws endangered their lives. Among these women included a woman with an anencephalic fetus, that's a fetus that has no brain and cannot survive, a woman with premature rupture of membranes and a non-viable fetus who was forced to wait until she was septic and facing organ failure before there was intervention, a woman carrying twins where one twin had a lethal malformation and where intervention was critically needed to save the other twin, and a woman whose fetus was abnormally attached to the placenta, incompatible with life, who was actively bleeding. Most of these women had to flee the state to receive medically necessary care, and all suffered greatly. They lost the case in May of 2024. The other thing to know about this case is that, as in other states, Texas law contains an exception for medical emergencies, but the language is extremely ambiguous, and physicians are very fearful because of draconian penalties that include up to 99 years in prison and not less than $100,000 of fine, not to mention loss of licensure. And the doctors in this case were seeking further clarification of the language but no further guidance was provided, and the case was lost. Next. So not only in Texas, but in many states with bans, we are now seeing harm to those facing severe pregnancy complications because physicians are caught between their mandate to prioritize patient well-being and avoiding criminalization. We're seeing significant harms with situations like these. This is just some. Obstetric complications, including pre-viability rupture of the membranes. That's rupture of the membranes. When that happens, most of you know there's no going back. And when that happens too early, there must be intervention. Ectopic pregnancies. These are embryos that embed themselves in places other than the uterus, like the fallopian tubes or a cesarean scar. This puts the pregnant person at great risk because these will rupture, and to save the health of the patient and the fertility of the patient, intervention is needed. Severe fetal anomalies. The standard of care in this country is to have a screening ultrasound at about 18 weeks. Oftentimes, those screening ultrasounds occur before then, but very often they don't. So these are often discovered mid-trimester. Again, often indicating a medically indicated procedure. Spontaneous miscarriage. About a third of all pregnancies end in spontaneous miscarriage. When that happens, the pregnant person is at risk for bleeding, and almost always intervention is needed either with aspiration or with medication abortion. So this too, and we are hearing a lot of reports of women with spontaneous miscarriages who are being turned away from emergency rooms and left to miscarry in bathrooms and parking lots. Medical conditions, chronic or new. There are many conditions that put women at risk, autoimmune diseases, cardiac diseases. There are any number of chronic conditions that may require medical intervention. The other thing is new conditions. What about a pregnant person who is newly diagnosed with cancer and needs life-saving cancer treatment that is teratogenic? So in all of these are just some of the universe of pregnancy complications that would require a medically indicated abortion. Next. The Kaiser Family Foundation surveyed OBGYNs in states with bans, and those surveyed reported that their patient care was significantly impacted in many ways. 40% of OBGYNs reported constraints on the management of miscarriage. 37% reported constraints on the management of pregnancy-related medical emergencies. These were just some of the problems that we were seeing. Next. There's also been an impact on training. The American Association of Medical Colleges reported that there has been a decline in medical student applications, especially in states where there are bans. So in states with bans, more than 10% decline in medical student applications to OBGYN residency training programs, and more than 7% to family medicine residency programs. Next. There's also been an impact on OBGYN training. Since 1996, the Accreditation Council for Graduate Medical Education, which is the governing body for all graduate medical education, they've required routine training in complex family planning and abortion care because all OBGYNs must be able to care for people experiencing pregnancy loss and must be able to manage pregnancy complications and emergencies. And to be board certified, the American Board of Obstetrics and Gynecology requires dedicated training experience. Now, due to Dobbs, if a program is in a jurisdiction where this is unlawful, the program is required to provide access to those who seek it in a jurisdiction where it is lawful. Next. So what you're seeing is that there are now strategies, back one slide. There are strategies where OBGYN residents have to travel across the country to complete their training requirements. And you can imagine how onerous this is for the programs and for the residents. Next. There's also been an effect of Dobbs on practice planning. So this was a survey that was reported in 2023, where 18% of OBGYN residents indicated that the Dobbs decision changed the location of their intended future practice or their future fellowship plans. And it is worth noting that physicians in training commonly remain in the states where they train. So what this does is further decrease the physician workforce. Next. So talking about workforce, medical professions now have to question whether to start or to continue their careers in states where there is a risk of criminalization for following the medical standards of care and where practice is defined by legislators without fundamental medical or scientific knowledge. It should not come as a surprise, for example, that in Idaho, since their ban went into effect, they have lost 22% of their obstetricians who have left the state. Next. So what we're seeing is a loss of OBGYN subsequent to Dobbs, and that is superimposed on a growing physician shortage and a worsening of what are called maternity deserts. Across the country, fewer than half of all rural counties have a place to deliver a baby. They don't have practicing OBGYNs or labor and delivery services. So we're seeing worsening maternity care deserts occurring in the states with bans, even as there's an increased demand for obstetric care. We also know that the lack of prenatal and obstetric and postpartum care increases greatly the risk of maternal and neonatal deaths. Next. This is a slide. This is the map that I showed you earlier, where you can see the abortion restrictions across the United States. And on the other side of the slide, the blue map, which is from the American College of Obstetricians and Gynecologists from 2024, that shows you pregnancy-related deaths. The darker the blue, the worse the statistics, the worse the maternal and neonatal outcomes. You can see for yourself the relationship. Next. The University of Colorado Population Center used data on maternal mortality and births and abortions to calculate the projected impact of pregnancy-related deaths due to abortion bans. And they projected an overall increase of at least 21%. These figures are a little hard to see, but at least 21%. And of course, much worse in Black and minority women. Next slide. Just 2 days ago, in JAMA Pediatrics, a study from Johns Hopkins reported an unexpectedly bad increase in infant and neonatal mortality in Texas that has accrued since the ban, 12.9%, which is worse than was anticipated. We need more research to try to understand this data. This is brand new, and to determine the contribution of factors, lack of care, premature delivery, congenital malformations. We're still trying to understand this, but it's quite striking. Next slide. Another issue that has ensued from Dobbs, pharmacists are caught in the middle. Louisiana this year passed a bill that arbitrarily reclassified the medications used for early abortion as controlled substances, even though there is no potential for addiction or abuse. They made it hard to access these meds. you have to understand that these meds are also the standard of care for the treatment of spontaneous miscarriage. You have to make sure that the uterus is empty. And so these are commonly used 60% of the time. And the arbitrary reclassification has made care that much more difficult. Next slide. Another area, Okay, here another issue for pharmacists. Ambiguous laws have led to interruptions in care for women with rheumatologic diseases. Methotrexate is a cornerstone treatment for severe rheumatoid arthritis. However, because methotrexate can also be used to treat ectopic pregnancies, women with active rheumatic disease who are dependent on their methotrexate have now reported problems getting their medications in many states with these bans. There's been a host of problems for women with rheumatic diseases. Next slide. The impact on infertility medicine. We are looking at possible restrictions on IVF that are an unintended consequence of Dobbs. The Alabama Supreme Court ruled that frozen embryos should be considered children, using the Bible as the basis for legal reasoning. And this has had a chilling impact on in vitro fertilization clinics, because what happened is the Dobbs decision has opened the door to interpretation of when life begins, but that poses a threat to standard techniques that are used, such as pre-implantation genetic testing, which allows for parents to identify healthy embryos and to dispose of abnormal embryos. Pre-implantation reduction in the number of embryos to ensure a viable embryo and reduce risks. This court decision could really substantially restrict access to in vitro fertilization. And you should know that about 2% of pregnancies result from IVF in the United States. So this is another area of concern. Next slide. The impact on emergency medical care. There is a federal law called EMTALA, the Emergency Medical Treatment and Labor Act, that was established in 1986 and which mandates that anyone who presents to a hospital emergency room who has an acute serious emergency must be treated or stabilized according to the standard of care. In Ohio, they have decided to sue the United States. This is now before the Supreme Court. This ruling is forthcoming any day now. The Supreme Court is now considering whether EMTALA preempts Idaho's abortion ban in situations where life-saving or health-saving abortion is needed in an emergency medical condition that otherwise threatens serious harm to the pregnant person. A potential consequence of Dobbs could be the gutting of this law that has been fundamental to emergency health care in the United States for decades. So this remains to be seen. Next slide. The impact on health equity. Dobbs is superimposed on, I am sure you are all aware, on existing disparities and health access issues. The United States ranks 39 of 39 among wealthy industrialized nations in maternal mortality. That means we are the worst. We are the lowest of the 39. Maternal mortality rate in the United States is also increasing more than any other industrialized nation. Black pregnant people are almost 3 times more likely to die in pregnancy, and it should come as no surprise that racial and ethnic disparities in reproductive health outcomes follow from baseline inequities in access to health care. Next slide. So restricting access to abortion and contraception impacts poor and minority women the most, and those with the fewest resources will incur the greatest consequences. There's a quote on here from Dr. Diane Foster. This was in the Journal of the American Public Health Association. The evidence that not being able to get an abortion leads to greater poverty and a worsening of physical health outcomes means that we are about to see a deepening of existing inequalities. Next slide. Dr. Foster was the principal investigator on the Turnaway study. The Turnaway study was a study of almost 1,000 women from across the country who were studied longitudinally over years. And the aim basically was to describe the consequences of receiving an abortion compared to carrying an unwanted pregnancy to term. They looked at physical, mental, and socioeconomic outcomes, and over 50 papers have been published about this study. It was extremely telling. Next slide. The bottom line is that we have robust data that shows that restrictive abortion policies will increase the number of children born into and living in poverty, increase the number of families experiencing serious financial instability, increase racial inequities, and put significant additional pressure on our under-resourced social welfare systems. Next slide. So here we have, well, a situation where Dobbs has created major barriers in terms of access to medically indicated abortions, and as you've seen, has led to other highly significant consequences. This slide is quite stunning because what it shows you is that there has been no effect on the overall incidence of elective abortions. So that, and this data is from the Society of Family Planning, who captures all this data each year. While numbers are down in states that have abortion bans, the numbers are up in bordering states and in other states where abortion is protected. And in fact, there is a slight increase this year in the total number of electives. There has not been no decrease in the incidence. Next slide. So I thought we could talk a little bit about what can be done to mitigate the consequences of Dobbs. State level policies to protect access include things like shield laws. These are laws that protect patients and providers from criminalization and extradition to other states for providing care that is legal in the state where performed. In other words, if a woman comes from Texas to Virginia and has a legal abortion in Virginia, the provider cannot be criminalized or extradited, nor can the patient or those who assist the patient. Quite a number of other states have enacted shield laws. The General Assembly of Virginia did pass a shield law last year, but it was vetoed by the current administration, but it will be back. Other state level policies that would help would be to ensure public and private insurance coverage of abortion care and to help safeguard sensitive data and strengthen privacy protections. Next slide. Have to talk a little bit about ballot initiatives. This is really interesting. When people can vote on the issue, the majority of people want to protect the right to make and carry out decisions about one's own pregnancy. California, Kansas, Kentucky, Michigan, Vermont, and Ohio have all voted on state constitutional amendments, and the side favoring access has prevailed in every case. In the coming year, Colorado, Florida, South Dakota, New York, Maryland, and Montana all have upcoming ballots to protect autonomy and prohibit the state from denying the right to abortion before viability. And after viability, doctors could determine whether abortion is medically necessary to protect the life or health of the patient. This is a complicated process. Getting a ballot, successfully getting ballot initiatives is complicated because in some states, it can be initiated by citizens, by getting enough signatures on a petition. But in other states, like Virginia, we can only get this on the ballot if it is legislatively referred. And in particular, in Virginia, it has to go through the General Assembly and pass through the General Assembly for 2 consecutive years. So it will not be easy to get this on the ballot in Virginia, but it may make it. We are going to see other states also trying to get ballot initiatives out there. So there's a link on this slide to the Kaiser Family Foundation, which gives you lots of information about this. Next slide. So Dobbs has made us re-examine the role of hospitals and teaching institutions in preserving and enhancing access to abortion. In particular, academic health centers have a pivotal role in training future providers, in advancing best practices, in using their influence in the public domain to shape policy and to provide equitable care to all. Next slide. And academic health centers are uniquely positioned to expand the provider pool and to train across disciplines and professions to support research that will help us in understanding the new landscape and to protect faculty and staff from undue legal risk. Next slide. After Dobbs, there was an academic health center in Ohio that created an interdisciplinary reproductive health task force with representation from executive leadership, multidisciplinary physician experts, hospital legal counsel, and government affairs, and a coordinated response was developed to provide clinical and legal guidance to healthcare professionals throughout the institution to mitigate confusion and reduce hesitancy to provide legally permissible care. This was a model institutional response. Next slide. But all systems can mitigate the consequences if there is a comprehensive institutional response, because inaction will only worsen the consequences. And I will share with you that this was going to be the last slide of my talk. However, next slide. On June 20th, there was a bit of a bombshell in the Richmond Times-Dispatch where the leadership of the Bon Secours Mercy Health System disseminated a letter saying, as state and federal legislation around medically necessary abortion is in flux, we are assuring our physicians and clinicians that Bon Secours Mercy Health stance is clear. We will back our physicians and clinicians as they do what's medically necessary and best for our patients. Next slide. They went on to say that in emergent situations that present serious risk to the health of the mother, when providers prioritize patient care and follow hospital policies and medical standards, they can expect the full support of Bon Secours Mercy Health. And this is really quite remarkable. While each state may impose its own requirements and expectations, a helpful tool for dealing with this uncertainty remains the continued exercise of well-reasoned, thorough, and professional judgment in accordance with recognized medical standards. And they closed with a statement of support for the Emergency Medical Treatment and Active Labor Act that I had described previously, EMTALA. So I was surprised to see this leadership at the coming from a Catholic health system, and I applaud them. I'm hopeful that other health systems will follow their lead. Next slide, please. I'm hopeful that other health systems will follow their lead and take this and other steps to protect access. So next slide. This is just a recap of some of the things that I have touched on today. It's a lot of information. Next slide. And I just wanted to reinforce that everything that I have discussed is data-driven, and I've got references at the end of my slides. Next slide. And next slide. I am very happy to take your questions. So thank you for your time. Okay. Yep.
Thank you very much, Dr. Klein, for that very compelling and informative talk. And I know we all learned a lot about the complexity of this issue. So we are going to invite people to bring questions forward, and our communication administration team is going to be kind of providing those questions to me to bring to your attention. In the meantime, I thought I would just ask one question. I appreciate the specific information that you provided about what state level policies kind of impact this issue, what can be done. Also, the emphasis on academic health centers, since VCU is an academic health center, and thinking about, you know, the role that they can play in terms of public awareness and training and things like that. As a sociologist, I particularly appreciate kind of the system level, institutional level things that can be done. But I was curious if you had thoughts about, you know, kind of individuals who may have come to your talk because this issue matters to them individually, kind of thinking about where we can put our efforts, where would be the best way for us to kind of try to increase women's reproductive autonomy. How can we do that besides supporting the policies that are coming?
Yes, you know, the simple fact of stepping up, you know, abortion has been stigmatized and marginalized. And one of the things that I tried to show in my talk today is that, first of all, medically indicated procedures, there must be a way to provide these when needed. There really is no way to make a list of all the exceptions in the law. So there's going to have to be more general language that brings it back to medical standards and judgment. But also we have to be able to speak about this from a morally compelling standpoint that I have found over the years that people are afraid to be supportive about abortion. And now it is all these rights to bodily autonomy and reproductive autonomy have been overturned. And suddenly people are less afraid, but speaking up, speaking out, voting on the issue, supporting advocacy organizations in every state. And, you know, voting on the issue is a big part of this. One of the questions I'm seeing was about at the student level, supporting research. I mean, you know, I think as I prepared for this talk, I learned a lot myself. There is so much material that is now being written and studied in all arenas. And I would encourage people to read more, learn more. Publications are coming out every day now to try to assess the Dobbs impact and the health consequences on our nation. So, you know, just stepping up.
Thank you. Another question, I was curious about the training. You mentioned training of OBGYN physicians in particular, but I was curious if you know whether these new restrictions are affecting other medical professional training, like nurses and others.
You know, unless there is a okay, so it's not just about physicians. There is a team approach in all aspects of healthcare. Nurses, advanced practice nurses, nurse practitioners, physician assistants, everybody who works in a hospital, you know, we all need to be cross-trained to deal with these issues with pregnancy loss. I gave the example of the academic health center in Ohio that created a unified response and disseminated that information throughout its institution. And it led to, you know, it was really interesting and well received. There was an article written in, I think it was either New England Journal or JAMA, that compared that with another institution that has not taken, and simply comparing those two institutions, The other institution has not formed any kind of comprehensive response. And so people are afraid. They don't know what to do. In the emergency room, a pregnant bleeding patient, in states where there are restrictions, people are afraid for their own licensure. Unless there is support and guidance and clarification, then we're going to see more instances of situations where pregnant women are turned away rather than being cared for. But, it's a collaborative effort. And on one of the slides, I mentioned that we need to be cross-training because this is it's a team sport, medicine.
Yeah, I thought that was a great example and similar to what has been happening for a while in the area of gender-based violence, these coordinated community response teams, right? Recognizing that there's so many different providers and people who come into contact with someone in that situation. So kind of recognizing the broader kind of socio-ecological issue that it's not just one type of provider that needs to be involved and needs to be informed. So.
Yes, and I see that someone posted a very helpful link. Someone from the Health Brigade posted a link to an article about integrating abortion care into primary care. So, 60% of abortions now are medication abortions. And the law does permit that those can be performed in any number of practices in offices, not hospitals, but those can be prescribed. The problem is people don't know how to do that. So we could broaden that training across fields throughout primary care, family medicine, as well as OBGYN.
Great. Let's see. Another question from the chat is, many of the states that have supported the right to choose ballot initiatives continue to elect representatives who support abortion bans. Do you think they don't see the connection, or is it something else?
That's such a good question. I don't understand. If I don't the landscape of national politics, it escapes my comprehension right now. I don't understand, other than to assume that people don't know the implications. Most people don't recognize all these consequences. Most people, for a lot of people, if it's a religiously held belief, it's one thing. But for most people, it's not. According to polls, 63% of the United States population supports access to abortion. So, they just need to vote on the issue, because it will come back to, everybody who's listening to this talk knows someone who's had an abortion. Abortion is a fact of life, and we need to talk about it, and we need to vote on the issue.
Let's see. Are you aware of any research, any data that's looking at kind of the very negative consequences of these restrictions on people who are attempting to end their pregnancies themselves? I know that that's always a concern when it's so much harder.
It's a great question. I came of age in the time when abortion was illegal and women were showing up bleeding to death every single day in the emergency room. One of the compelling reasons that Roe v. Wade was passed was to save lives, because women were dying all the time from unsafe abortion. So now the question is, are we pushing people back to a place where they will self-treat and incur risk? The good news is, with the advent of medication abortion, we have a technique that is very, very safe. There was another article this week in JAMA that talked about the safety of telemedicine medication abortion. The thing is, that can only be done up to 10 weeks. So beyond that, a medication abortion is not acceptable. Are we going to be pushing women to do unsafe things? I believe so. If there are states with bans that don't allow options and women can't afford to travel, yes, I see. But again, we are only beginning to accrue the data that we need. So we have to wait. There's lots of people looking at this now, but it's only been 2 years, and it's very hard to capture the data and publish the data. So a lot of people are working on that.
Thank you. Another question from the chat. How do you suppose we can get more men invested in this topic to take action? It seems that so few cis men are investing in understanding and protecting bodily autonomy and abortion care.
Share this slide, share this talk. People are ill-informed about the broader consequences. And so, I think just educating people. I see a question here about how can we change the laws in Virginia to allow citizen initiatives. We can't. It's a very good question. And that one slide, if you go to the Kaiser Family Foundation page where they talk about how in each state you can create a law to protect access. The problem is some states, it's a matter of collecting citizen signatures, which has been done in all of the states where it's on the ballot this coming November. However, in Virginia, as an example, this is our state constitution, and the law says that we have to get a ballot initiative on the ballot, it has to pass through the General Assembly for 2 consecutive years. I think you can't, I don't know how we would amend the state constitution to change that. So what we have to do is make that happen.
Great. People are traveling to safe states if they're able to. Are reproductive healthcare clinics in safe states able to increase their efficiency with more staff and facilities?
That is a wonderful question. And I don't know, but I had one bullet on one of my slides that was a plea to health systems to increase capacity. But we are definitely seeing an increased demand in the states that are protective of abortion, and women are traveling. We're seeing organizations stepping up to provide assistance with travel. There are now organizations to which people can apply for assistance because getting to another state is costly and time consuming, but there are now pathways to get that done. The big question is, will states who are protective, will the demand exceed their supply? Because it's scary. This is something that has to be timely. So what we don't want is for people to have to wait for appointments in this. For example, if people come from Texas to Virginia, we want to be able to meet that need. And so it's going to take a village to make sure that the need is being met by the clinics that do provide care. It's been to our disadvantage in this country that abortion care has been marginalized. And as you know from my talk, yes, there is a difference between elective abortions and medically indicated abortions. I would support that decision should remain with the pregnant person and the healthcare providers, no matter what the indication. But yes, we are going to see more problems where the need may not be able to be met.
Do we know if any of our local hospital systems, aside from Bon Secours, are having any strategic discussions about all of these overlapping challenges and how they're addressing them?
Excellent question. One of the reasons I ended my talk with the slides that I did is that I don't think that health systems are stepping up. I am marginal. I don't know. But I think that only Bon Secours Mercy Health has come out with this public statement, which I think is extremely laudable, and I'm hoping others will follow suit. But I am not aware of any other health systems going public with support. So.
Thank you. How are crisis pregnancy centers, also known as abortion diversion clinics, which have been expanding in recent years, benefiting from these new laws and regulations?
That's a loaded question, but crisis pregnancy centers are centers that present themselves as medical clinics, but they are not. They don't have medical providers on site. They have people who provide resources to sway people away from abortion. And they have been, that's all that's really all I can say. A crisis pregnancy center is not a medical facility.
Great, that's helpful. We have a comment from another participant. I have so many reasons to thank you for your thoughtful presentation, Dr. Klein, not least as someone who has had 2 abortions to resolve incomplete spontaneous miscarriages and pregnancies that I very much wanted. Now that I'm parenting an adolescent, I'm concerned about policy expansionism to restrict pregnancy prevention, for example, hormonal birth control, IUDs, etc. I'd love to hear your thoughts on that.
That's another excellent question. I am fearful that there will be attempts to restrict access to contraception. I think that even though we know that long-acting reversible contraception, that is IUDs, we know that those do not cause abortions, they prevent implantation. But for those who are extremely opposed, the same folks who would like to restrict in vitro fertilization will be coming after some forms of contraception. And I think, again, voting on this issue, if you are voting for people who don't expressly support access to contraception and bodily autonomy, then you may see our other rights begin to disappear. The Comstock, I'm sure you may be aware that there is an old law on the books called the Comstock Act, and there are people who are trying to legislate access to contraception. It's very regressive, but yes, there are risks wherever there are bans.
Thank you. And then we have 2 questions, very similar, asking if you have any information or data or research on how mental health outcomes or patterns have been affected these last couple of years. The mental health impact of the Dobbs decision, I guess.
Yes, so really excellent question. People are trying really hard to understand the effects. JAMA, I'm holding in my hand they wrote a whole issue last year called Healthcare Access and Reproductive Rights. I mean, fascinating. And the Journal of Women's Health is working on a special issue that's looking at this. Lots and lots of research is being done now to try to capture this data, but it's so new. Right. It's so new that it's hard to, we all want to be able to capture the data that shows the devastating effect, but we have to wait for the data, and we have to do it in a very careful, intentional way.
Right.
So to be continued.
Yes. Thank you. I believe that we have asked all the questions from the chat and we are almost out of time. I want to thank you again for a very thoughtful presentation. I mean, I know a lot of effort went into that to bring all of that information together, especially the very recent developments that you included. Stephen, do I hand it over to you now?
Absolutely. Thank you, Dr. Brubaker. Thank you, Dr. Klein. This was so informative, and I feel very privileged to have been a part, or at least participate in this presentation. And I feel and I hope the rest of our audience feels that they could walk away with more education, but not just more education, but ways to act on it. And I think that is probably the most important part. I provided Dr. Klein's email information in the chat. For those of you who did not have a chance to ask questions, but still would like to reach out to her with more questions. We thank again our communications team who works in the background. Thank you, Dr. Brubaker. Thank you, Dr. Klein, for this session. Last but not least, I invite everyone to join us on July 17th as we discuss another hot topic, the recent FAFSA complications and implications. And so we'll have Jill Disjean, Senior Policy Analyst for the National Association of Student Financial Aid Administrators, joining us to speak more on that. So we look forward to having everyone join us on July 17th. Thank you for sharing your lunch with us and taking time out of your day to be a part of such a great presentation. Thank you again, Dr. Klein, for that presentation. Everyone have a great day.